This is our final panel for today, and they will be exploring the new landscape facing healthcare delivery in rural communities. I'm pleased to be able to introduce to you again Chris Masingill. Chris was on our panel, opening panel on Thursday, but today he's going to be serving as moderator on the rural health discussion, and he is the federal co-chairman of the Delta Regional Authority. Chris was appointed by the President and confirmed by the U.S. Senate in 2010, and his 5 years of service, Chris has made it his hallmark to develop strategic connections between the public and private sectors to achieve economic and community development results on the local, state, and national levels. Previously, Chris served the state of Arkansas as Governor Mike Beebe's Director of Intergovernmental Affairs, and during that time, was the Arkansas Recovery Implementation Director, coordinating the implementation of $3 billion of investment into 48 programs across 13 state agencies. Chris knows the challenges of rural communities across the Delta region and is well situated to moderate today's panel. So I thank you for being here and welcome.
Thank you very much. I'm just going to hang tight right here. We're going to make this a lot more conversational with the group that we've got right here. But Diane, I want to say first and foremost, thank you very much for your leadership. Thanks for letting DRA be a partner of the Southern Governors. And I feel like I've had a connection to SGA for a long time, even during my time with Governor Beebe. It is a valuable organization, one that serves the states extremely well, and your leadership and your team is wonderful. So thank you for the partnership that we have. And thanks for the dinner last night. Dinner was fantastic. We enjoyed that. Jeff, it's great to be in your state, and that was an incredible facility, and enjoyed the rooftop last night. That was an amazing view. And so this morning, though, this is actually very, from my perspective, and particularly what we do every day. You know, yesterday we were talking about workforce training and education, and now we're talking about health. And those two, from my perspective, one as an economic development practitioner, and then one as a principal of an organization that was created to help serve rural communities, to help do community and economic development. When we talk about these issues, they have a direct link. The health of a community is vitally important to creating a healthy workforce. And without a healthy workforce, you cannot be competitive in a 21st century global economy trying to be competitive like we are. This issue for me, too, is also at the heart of some of the stuff that we're trying to do for some of our rural communities, trying to leverage, trying to bring a holistic community solutions approach to the table. Chuck, you mentioned yesterday this urban-rural connection, so vitally important. We know some studies say that the increase of GDP by 5% when there is a strong connection between urban and rural. We believe that firmly. We believe that strongly as an economic development strategy. And as a part of that economic development strategy, this is where this issue of health for us, the Delta Regional Authority, is so important. Of course, it's important when it comes to access for individual people and the health of individuals and communities. But quite frankly, from my perspective, this is also a business issue. This is also an economic development issue. This is an issue for communities to be competitive in trying to close deals in our part of the world. We know that, at least it's been my experience trying to close deals, that first question out of the mouth of CEOs or site locators is always the question of education. But over the last 5 or 6 years, what I've seen is that the second question in the course of that conversation is health. Not just health access, but how healthy are your people? What's the infrastructure of your health economy? We also know that in a lot of our communities, particularly in rural America, the #1 employer in the county is the hospital and the physicians. We know that this is going to have a continuing dramatic impact on our local rural communities. In fact, I'm sure some of you all have seen the figures, the number of hospitals that are closing. In fact, it was interesting in preparing for today. I hadn't seen these numbers in a while, and it actually, Chuck and Dr. Bazemore, you can appreciate this, I think, specifically, because when you look at my footprint, and I didn't realize this, I have worked on a few hospital closing issues, even during my short time at DRA. But over the last 5 years, 57 hospitals, 38 hospitals within the 16 states that make up SGA, and 13 hospitals of that 57 were directly in my footprint. And you start thinking about that, and you're like, wow, this has some significant impact. I dove into those numbers even more, and from an economic development perspective, it even shocked me even more. There's another 283, evidently, that are targeting or vulnerable for closures. That has the potential to have 36,000 jobs impacted in rural America in the 16 states that represent SGA. What was really startling to me as well is that if those 283 or so that are still targeted across the country has a potential impact of $10 billion in lost GDP. Now I start thinking about that, and from my perspective, that is very scary. We talk about the innovation pieces yesterday and technology. We know that this issue is tied to all of those. We know innovation is going to be very key to this conversation. We know new ideas, new ways of thinking, new models are going to be very important for this discussion of understanding the rural landscape for healthcare. I'd also like to say before we get to our speakers is that this issue is also about transportation for us in rural America. This is also how do we address this issue in terms of building communities' competitiveness. For example, we've spent directly over the last 13 years of our investment cycles, quite a bit actually here in Missouri, with DRA dollars going into health care related projects, almost $13 million that has also been a part of a leveraging of $130 million worth of health-related projects. Everything from helping to build surgical units, buy equipment, recruit physicians, build clinics. In fact, one unique story, Hickman, Kentucky. That's why I wish the governor was actually still here. He and I worked on this project. We were able to come in and help establish a new clinic in Hickman, Kentucky. Individuals were having to drive 60 miles just for that basic family care and those related services. So this issue is obviously very important. It's very important to us from multiple aspects, and I'm certainly glad to be here with our panelists today. You all met Chuck yesterday, and Chuck, thank you again for being a part of the panel today. Dr. Bazemore, who is the director of the Robert Graham Center for Policy Studies and Family Medicine. This gentleman is clearly no stranger to these issues here in this subject matter, being a professor and associated with many fine institutions like Georgetown and George Washington, a member of the American Academy of Family Physicians, and obviously with your work at the Robert Graham Center, which I found actually very interesting. And Chuck, I had mentioned to him before the deal, I want to have a sidebar afterwards, because what's interesting is that really trying to influence public policy from the perspective of a family care physician. And so for us in rural America, that family care physician is everything to us. It's the specialist. We go to that individual for everything, and having that perspective, I think, is pretty unique. So Dr. Bazemore, thank you. Chuck, thank you. And then our third panelist, Zane Yates, who is clearly no stranger to the folks here in Missouri, actually former legislator. So he understands those policy dynamics as it relates to rural health care and these kinds of issues, being the Vice President for Business Development, and on the road too, it sounds like, and going to have a unique perspective from the private sector of how this issue impacts rural America. So let's start with Chuck, and they're going to give about a 10-minute or so presentation, and then we'll come back and have some Q&A and interaction. Thank you, Chuck.
Thanks, Chris. It's great to be with you again. This is obviously the rural component of this conference. It's usually last. Usually you have to go through 3 corridors to get there, and when you're there, there's no seed corn caps, and the coffee's pretty much all gone. Thank you for staying. I want to echo something Ted said yesterday as a point of personal privilege. This region's extremely blessed to have Chris's leadership. And as he shared about SGA and Diane, Chris is making a huge contribution, and we need to acknowledge how important DRA has become and what a great job Chris is doing. He's a colleague I very much value. Talk for a minute about our organization and the message I'm bringing, the Aegis for us. We've been congressionally funded for 25 years. We were started by the United States Senate with one sole goal, not to advocate, but to try to create an objectively based rationale for a rural choice to share with decision makers quietly and one-on-one our assessment of the rural differential in their decision. Consequently, that puts us a bit in tension with advocating organizations, but that is why a policy shop exists. We began work on a rural health panel 25 years ago when Clinton introduced the Health Security Act to look at the rural differential there. We have worked at health systems change in the last 25 years through a number of studies on rural health reform and rural systems dynamic for the Office of Rural Health Policy. We have a center in the College of Public Health that is congressionally competed each year. We also have a National Rural Health Panel made up of the leaders, I believe, in the practitioner and research community of the field. Most of the significant rural health research directors at the centers around the United States. The current administrator at HRSA, Mary Wakefield, was on our panel. We're very honored in RUPRI to work in a way that's collegial and we believe offers something unique because we are on the ground in most states looking at the research questions about systems. In January, Secretary Burwell offered a very aggressive approach for how we move to value-based payment. At that time, the Federal Office of Rural Health Policy asked us to look at could rural get there and what might we do if we were heading that direction. So Diane has given me 10 minutes to do a 2.5-hour overview, and I'm on it right now. I'm going to avoid two things, tech talk. I know many of you aren't health staff, but I do want to try to tee up the key future drivers that's going to frame the rest of the discussion. Any similarity between yesterday's discussion of systems change and this discussion is purely intentional. I'd like to do a couple things in the time I have. I want to acknowledge changes here. It's not moving back. That's going to create some opportunities as well as some threats. I'm going to raise a question, why won't incremental change work? I'm going to ask what hospitals and organizations can do, and then what are the results we believe make sense. Now, we've had major crises in rural health before. There's 3 of them that are significant, and they resulted in systems change. Originally, when hospital care was the cornerstone, the rural challenge was solved by the Hill-Burton. That was 1946. Then as we moved through and the hospital financial structure was challenged by prospective payment, we created a state flex program, which was highly successful. It became the critical access hospital program. Today we have a new challenge, and that is we're changing how the site of care and the value of care is assessed. The real rural challenge here needs to be answered around 3 or 4 factors. First of all, more than anything else, our population is aging in place. There's an increasing prevalence of chronic disease in our rural constituencies. Changes in patient revenue sources are more challenging in smaller institutional framings, and we need to raise the question, can small-scale independent hospitals and practitioner units survive? The shifts are out there, they're coming fast. The insurance coverage shift goes from health insurance marketplaces, private exchanges, narrow networks that are working. Public programs are shifting to private plans, and we're moving from volume of service for which you get paid to value. That is a huge change. The evolution in Medicare payment is one example. We started out in fee-for-service, no link to quality. We moved to fee-for-service with some link to quality. We've now moved to alternative payment models, build on that fee-for-service infrastructure. Now we're down to population-based change. Let's just look at Medicare and Medicaid for an example. Secretary Burwell's challenge was to take 30% of Medicare provider payments to alternative payment by 2016, take 50% of those to new payment models by 2018, 85% of Medicare fee-for-service tied to quality in 2016, and 90% tied to quality and value in 2018. She is about to achieve the top number of both of those. We are moving at warp speed. This parallels where private insurance is going. I'm not going to spend time on this, but this is a major private sector dynamic. Their goal is to take 75% of their business to value-based arrangements by 2020. Major private sector and, to some extent, less private sector, but service-based integration is occurring here. I'll come back to that in just a second. CMS has 3 goals. Better care, smarter spending, and healthier people. Better care. They have major efforts out to change how this sector works. Comprehensive Primary Care Initiative. That's a multi-payer initiative. Multi-payer Advanced Primary Care Initiative, number of states. And changing how clinicians work in this system, a huge initiative. And one of my colleagues will talk about that probably in a minute. Smarter spending. We're going to pay for value with incentives. It's going to be hospital-based. It's going to relate to readmission. The new payment models are coming. There are many challenge grants out there. And finally, healthier people. Think about what I said earlier, our major drivers. Their goals are better to coordinate care for beneficiaries with chronic conditions, that is the rural constituency base, and partnership for patients to avoid averting hospital-acquired conditions, which is also a huge rural issue. So what's the cycle? Well, it's moving very quickly. It isn't a change of kind, it's a change of degree. Rural is going to have to get strategic, and they're going to have to change their dependencies. The fee-based model is gone, in my opinion. What are the goals of the system we're building? What are the strategies we'll use? How can we be rural-centric in thinking about that? And how can we align reforms so that it makes sense in a rural context? Well, here's what we need. We need a high-performance system. We have looked at a number of systems around the United States that are doing innovation. They have to be affordable, accessible, they have to be high quality, they have to be community-based, and they have to be patient-centered. Now, here are the strategies that we think make sense. Begin with what's vital in the community, and that means major needs assessment across all players. Build on an appropriate base. Every rural community is differently. We have to integrate different institutional designs and payment models. What are the approaches? There are basically four: community-based approach, new governance and integration, flexibility and facility and program alignment, and finance models that work. 1 second on each of these. Community-appropriate care, local determination, create workforce dynamics that keep people in that workforce in their place. Major study of nursing. If a community college trains a nurse within 20 miles of her or his home, 80% of those people end their career within 30 miles of that college. And use our grant programs more wisely. Secondly, what do we do in governance? We have to bring programs together to address needs, and that's going to happen at the community level. We have to build a collective decision-making process. What do we do in facility flexibility? First of all, emergency care has to be sustained, but then we need to think about other models after that that move us to global budgeting around value. Third, we need financing models that promote investment in delivery system reform. Those don't exist as well as they should yet. And lastly, we have to think about shared governance. If this sounds like yesterday, it's supposed to. We need regional approaches. They have to aggregate and merge programs and investments. They have to connect to personal and community health. Robert Wood Johnson has a major new initiative in the culture of health. We believe that's critical. And lastly, we have to have a backbone organization to do that. Here's what you need: a convener that brings those parties together. It could be a public, private, or philanthropic convener. You have, critical to the success is a common vision for how that narrative will work. You have to have a backbone organization. It is clearly a collective impact model. If you do not know about the Stanford study of collective impact models, I urge you to go to the Stanford Journal of Innovation and read about it. It is what we're doing in healthcare. Lastly, we need some fundamental strategies. We have to go where the spend is and get the savings there. We have to get outside of the walls of our institutions into the people. We have to collaborate. We have to have common goals. Lastly, here's what we think we need: an accountable care community component. Partnership, a backbone organization, specifically technology, because if you cannot prove value is coming, you will not be getting the money. Leadership for strong integration, local champions, and targeted programmatic efforts. I hope this tees up the rest of the session. Thank you.
Great, thank you, Chuck, very much. Dr. Bazemore will be our next presenter, and while he's getting his presentation prepared or getting ready, I'd like to say a special thank you and hello to Dr. Wanda Fowler, who is now the new president of the American Academy of Family Physicians. So thank you for taking time to be here. It's very important. You being here sends a strong signal. Dr. Bazemore?
Thank you. And thanks, Diane and the Southern Governors Association, for letting me come and speak. I think Chuck has really teed up the issue beautifully, and I'm going to focus a bit around the primary care function that, as Chuck's mentioned, really serves the needs of rural America, and specifically its workforce. Who's going to staff these critical access hospitals and keep them from continuing to close is a real critical question today. I want to start with a little bit of background. The Graham Center was started by the American Academy of Family Physicians. It's in its 16th year. It's a bit of a unique animal in that it was granted an editorial independence to go forth and perform studies and set an agenda to look at the primary care function. Figure out what works, what doesn't work, what do we need, and we do that through a whole series of studies around workforce, value, quality, service delivery. But I'm specifically today going to talk about our efforts to look at the workforce. And I want to start with a notion and a definition of primary care that we certainly use in our approach. It's not about one specialty, family medicine being one, and I as a family doctor know that as much as any. It's really about a function. And that function, as it was laid out in our Institute of Medicine report in 1996, was one that described an integrated approach, accessible to all, and the clinicians who would provide it really were ones who were supposed to take on and address the majority of issues that face the populations they served. They absolutely were to work and sustain partnerships with patients, and those patients would be to be viewed in the context of their family and the community that they lived in. And what was declared by the Institute of Medicine, this esteemed body of leaders across the United States, was that primary care was the logical foundation of an effective healthcare system, and one that was essential to achieving the objectives that together constitute value in healthcare. We haven't exactly lived up to that definition, and I want to share a little bit of a perspective ecologically on our healthcare system and on its delivery in the attempt to achieve health. We took a look at this at the Graham Center back in 2001 and have continued to advance looks at it ever since, and we noticed that it didn't really deviate from what Carr White, one of the founders of health systems thinking back in 1961, had documented. Carr was able to say, you know, if you take a look at how healthcare is actually pursued, and in our update in 2001 we followed the same logic, you can look at 1,000 people. You can guess that about 800 of them in a month are going to report some kind of a symptom, 327 are going to consider seeking medical care, about 113 of those are going to land in a primary care physician's office. And yet the vast majority of our spending and a lot of our attention in our healthcare system trickles down to one of the least common places where healthcare is sought and where health is achieved. Large academic medical centers, which do wonderful work, but nonetheless are hyper-attuned to illness, disease, and very, very subspecialized sectors of disease, not the broad parameters I described as the functions of an essential healthcare system. As a matter of fact, we estimate that if you look at spending in the primary care sector, we're sitting at about 6 to 7 pennies of the healthcare dollar going into primary care, knowing very well that the runaway freight train that is healthcare and healthcare delivery concentrates its spending on same-day hospital costs, procedures, things that are too far down the pipeline to really help us achieve health. We also know that if you look at primary care provider to population ratios, back to this workforce element that I'm going to talk mostly about today, it does matter how many you produce. As you see higher degrees, in this case in a study that we've done of FPs, family physicians, nurse practitioners, and PAs per population, as you get to higher and higher numbers per population, you start to see important outcomes begin to drop. Part A expenditures in Medicare start to drop, avoidable hospitalizations. We were looking at where that sweet spot might lie, and in an age where we've been taught that primary care physicians should be able to handle 2,000, 3,000 patients in a panel, we were showing that as you get down closer to 1,500 or even less than that, you see these avoidable hospitalizations and these unnecessary expenditures begin to decrease. I came back from Australia for fourth trip in 5 years, and I've been blown away by the difference in that healthcare spend. The fact that unlike our 6 to 7 pennies on the dollar, they were estimating something like 22 to 30 pennies on the dollar going into primary care delivery and into this function that I've mentioned. Now, my first experience with a critical access hospital, which as we've heard are threatening and decline, was in one that was doing pretty well. It was in Highland Cashiers, North Carolina. I'm a North Carolina native, and I was a North Carolina rural health scholar, and before I even started med school, they sent us up for a 2-week experience just to try to get us the kind of exposures we know are important to keep people in primary care and potentially in rural. Now, at Highland Cashiers, you were looking at what became, after 1997, a critical access hospital designee, and I was following a family doctor who didn't live in an outpatient box. As a matter of fact, I chased him for 2 weeks from his office across the street to the ER, up and down the halls of the ICU suite, occasionally lending a hand with his equally generalist buddy, the surgeon, in the OR, and occasionally back out down the street to his patient's home. And it really taught me a lot about what these entities meant for the communities. As was mentioned, this was the economic lifeline and the employment lifeline for the area where we worked. We've done a study that showed that doctors like the one I was following were responsible for about $1 million a year in economic impact on the rural areas they serve. You start teeing that up against other businesses, and you particularly look at the kind of staff that they bring into their offices with great diverse backgrounds and educations and what they mean to those communities, and you realize how critical these critical access hospitals are. The dependence of rural on primary care is not a hard thing to quantify. Now, I've seen a lot of different measures on how much of the U.S. is really still rural. I think if you use USDA estimates, we'll say it's about 15%. I've seen others say it's still as high as 19, maybe even 20. But if you look at the workforce and what lines up with rural, at least in my physician community, and I'll talk about others as we move along, you only get about 5 or 6% of the specialists who make up over 70% of all doctors today working in rural, compared to about 11% of the primary care physicians. You find a disproportionate share of federal funding needing to go to prop up this primary care safety net through rural health clinics, critical access hospitals, and teaching health centers, federally qualified health centers. Interestingly, we've seen over a 30, 40-year period where you're hearing cries to make more physicians, a growth in the physician-to-population ratio overall. Whoops, let me back up one there. What I'll tell you, though, is that the slope that's in dark purple and the black line are in parallel. All physicians per population has grown, but it's mostly been through the growth of specialists per populations, subspecialists per population. The primary care line is roughly flat over that same time period. But more alarming, and I just left the colors in without even highlighting the legend here, just to tell you that if you look in 2010 and you estimate utilization in primary care will stay roughly flat, we'll keep the same teams, we don't change a thing, and you change 3 factors that have already begun to change, you look at how much an aging population, a growing population, and an increasingly insured population under the ACA, under Obamacare, actually will impact primary care use, changing nothing else. We estimated you'd need 52,000 new primary care physicians just to accommodate those 3 factors. That's a big issue. Mind you, those models don't accommodate new approaches and teams, but if anything, we're thinking that the primary care physician, the primary care nurse practitioner, PA, should probably be dealing with smaller numbers of patients, not greater numbers. That this idea of growing teams may actually involve more resource and workforce investment in primary care, not less, if we want to achieve health, not just more health care, and if we want to keep people out of the hospitals, not depending on them more. The real issue, though, is not about supply. So we continue to make more. We ramp up our med school production. It really is about how you get the folks you need doing the things you need them to do for the people that need them most in the places where they're needed. This is an old 2006 map, but I'll tell you it hasn't changed much. It's a federal designation of health professional shortage area for primary care. And the main thing it highlights, a little deceptively because these counties are mostly rural that are in red, is that we have primary care shortage areas everywhere. You may have, at least at the moment, an adequate workforce. Now, I've told you there's some good reasons to believe that may not be true for long, but that workforce is not distributed equally. And how in the world, if you're accommodating your production increase, if you're building those factories that will make more, how do you accommodate maldistribution? How do you serve that function I talked about if most of your area is in the red? If you look at the child scenario, This is a really busy map. I'll just tell you to look for little pockets of red and orange, where we have estimated, using again, a series of workforce data sets, that you have 0 or less than 1 physician who care for children, namely pediatricians, family physicians, per 3,000 children in any area that lights up in red or orange. Now, it's hard to see in some of these areas, but I'll tell you that those are scattered throughout your states represented here today. Some providers are more readily found in rural currently. We showed in another analysis that your NPs, your PAs, and your family docs do tend to show up in the areas where you need them most right now. But your problem is your pipeline. We did a study looking at 2006 to 2008 outputs of the residency programs, the graduate medical education system that will ultimately yield the physicians that might work in rural. The reason we looked at 2006 and 2008 is you need to give them a little time to figure out where they're actually going to land. So we came forward and said, okay, if you look at all of the U.S. production, which is, again, receiving $15 billion in federal money and Medicaid money, again, public investment in graduate medical education, you're only getting about 25% of all production going into primary care. Your congressional advisory group on graduate medical education says you need at least 40%, maybe even 50% to go into primary care to accommodate our function and our needs. You're getting 25%. But take a look at rural. If you look at all that production over that 3-year period, we found about 5% of them working in rural. Your population, remember, in rural remains 15 to 19. This means that downstream we have a real problem looming for rural America. And where you train really matters. Those exposures, this is Highlandtown again, in these small areas, those abilities to keep folks who would be most likely to work in rural actually touching those small areas really do matter. If you send folks off, even from rural, to the big academic health centers, it's really hard to resist the whispers in your ear. You're too good for primary care. You're too smart for rural. You need to do something that really requires additional training and really ultimately keeps you here, keeps you in this area, keeps you near the big academic health centers and the hospitals. This is a busy slide again. We just went and looked on the far left-hand side. If you look at the training sites, these small factories that make residents that ultimately become doctors, on the far left are the hospitals, the training sites that have the fewest number of specialties. And guess what? The percent of the graduates that enter rural practice, that's that vertical axis, goes way up when you get into these areas that have very few opposing training specialties. What that really says is you're going to get your rural docs mostly from small community-based hospitals. Well, I should say your potential, your production is going to be at the highest efficiency there. You have to remember most training happens in these big hospitals to the far right where you have lots and lots, 80+ specialties in some cases. We have to figure out, on the one, how to make more of these small training facilities, and number two, how to make the ones that are the big training sites produce more rural. You have to figure out why you find in Geisinger, Mary Hitchcock Memorial, which is Dartmouth's campus, some outliers. What are they doing differently that makes them have more rural? Back to the touches. We've shown, looking at Medicare and Medicaid data, that if you can document resident training exposure to a rural health clinic, a federally qualified health center, or a critical access hospital, you'll have a far greater chance of having them practice there. I told you 5% of all residents in that 3-year window ended up in rural, 38% if they trained in a rural health clinic, 31% if they touched a federally qualified health center or community health center, which doubled, by the way, under both the Bush and the Obama administrations. 53% if they had touches, if they were delivering care in a critical access hospital. We know that these primary care docs tend to stay local. I've been asked for years, can you show us that number again about just how many? So we went and did this study a year ago, and it looks like about 56% of your grads in family medicine are going to stay within 100 miles of their area of training. So when you build these factories, if you build them somewhere close to where you want those docs, you got a pretty good odds that they're going to stay there. Rural training tracks, small in number, small in total productive output, but highly efficient as vehicles to rural, are taking, in one study, 70% of their grads in the 13 states back in 2001 are showing up in rural sites later. We repeated this because rural training tracks are back in vogue again. There are about 33 of them, we think, now. They produce maybe 1-2 family docs, internists, pediatricians a year. But guess what? Over 50% of them seem to be showing up in rural. Our trend line doesn't show much decay either. We thought, well, maybe a couple years after graduation, they'd all get back into the usual pattern of returning to urban or peri-urban. Nope, a little bit of decay, coming from 50% down towards 45%, but these folks seem to be staying in rural. We've just started this longitudinal study, and we'll see where these trends lead, but that's a pretty high return on investment for your rural training tracks. I think a final thing I want to note is it's not just about access. This is about the cost of care. When we went and did a very complex model that we boiled down to a pretty simple 3x3 table, which said, you know what happens to folks who train in low-cost areas when they end up practicing on Medicare and Medicaid beneficiaries versus people who train in high-cost areas? And we really detected something we've labeled imprinting. You imprint on the trainee the patterns of care that they experienced in training, and it lasts. If you train in a low-cost area, and guess what, those tend to be disproportionately your smaller community-based training sites, your rural sites, you tend to deliver care in a more low-cost fashion. And we showed, after modeling this and trying to control for many other factors, that this holds up 7 to 14 years. So your decay effect, which you would expect over time, you'll eventually start to look like the other providers around you. It doesn't come along for many, many years afterwards, and that's significant. So not only is the training important for access, it may ultimately, in fact, impact your cost. And comprehensiveness matters. I speak as a family doctor who was told as I came out of training, you're ready to go deliver babies, work in the hospital, the ICU, the nursing home, as well in the outpatient setting. Your procedural skills are going to include colonoscopy, sigmoidoscopy. You can go and do colposcopies. You can even jump in the operating room from time to time. I now practice a day a week, and I don't do a fraction of that. But even for my colleagues who did, we went and did a study saying, you know, you can measure comprehensiveness. You can look at how physicians report their services delivered and even track them in Medicare claims. And lo and behold, in a study we just put out this spring, if you measure comprehensiveness any of 3 or 4 ways, it lines up with lower cost. You tend to see the folks that do more stuff in my collegial family medicine environment tend to be associated with lower cost, even if you correct for the fact that rural is going to be lower cost to begin with. I speak to a couple of my colleagues from residency training. Richard Hudspeth on the left works in Hendersonville, North Carolina. He came out and went off and did an OB fellowship just so he could keep doing some of the operative obstetrics that he enjoyed so much. He was doing inpatient, outpatient, ICU, and everything. He ultimately had to move back to Asheville, North Carolina, because as he and 3 other docs took over the obstetric delivery for the migrant and most vulnerable populations in Hendersonville, the OBGYNs all left. And then one of his partners burned out, and then another one. And he found himself on an every other night rotation delivering a boatload of new children in the greater Hendersonville area. And he ultimately, again, was at risk of losing his family time and really his sanity to practicing this comprehensive care. Mark Huntington similarly was doing not only operative obstetrics coming out of graduation, he was in rural Minnesota as one of the only 4 docs within a 100-mile area. They were bringing in a general surgeon or teleconferencing a general surgeon so that they could do cholecystectomies and take out appendicitis, take out the appendix in an appendicitis case. He ultimately got a little burned out after about 8 years, and now he's still working in South Dakota, in rural, but in a teaching hospital in a much bigger setting. How you keep these guys doing this comprehensive delivery and happy in rural America really is our challenge. And this pipeline's broken for everybody. We're trying to figure out how do you keep not only the physicians entering primary care, but how about the nurse practitioners and the PAs? When you're in our PA study last year, we were discovering that our PA colleagues on the East Coast were coming up with double the financial offers when they came out of school to enter surgical subspecialties than they were in primary care. Finally, we are in an age of optimism. We have state innovation model grants. You've heard about other programs that I didn't want to overlap with Chuck, but I mean, your Oregon experiments with community care, your state innovation models, your primary care trusts, the attempts by states to get Medicaid waivers to actually boost training in primary care are all optimistic signs that we may be able to take this decentralized model and make it work. The extension of the Teaching Health Center program for 2 years is a help. But the states have to get involved, and they can't assume that insurance expansion is going to ensure any access. You give everybody a card, they still need a home. They have to have a place to go. This decentralized training works, and I would encourage you to look into ways in which states are doing it and doing it well. And finally, as payment shifts, particularly in the wake of our macro bill back in the spring, start to bring value-based purchasing and population care models to the fore, how do we make sure that the measurement is to the favor of generalism, of comprehensiveness, and of accountability in the way that we train so that we actually serve the needs of these rural populations? And thank you.
More, Zane? And while Zane is coming up, just a A little bit of perspective again, since I am the moderator, I'm going to highlight Delta Regional Authority footprint a little bit. So 252 counties and parishes, and Doc, you had mentioned the health shortage area and medical underserved area. So 252 counties and parishes, only 22 are considered not to have a shortage area, and only 7 out of my 252 counties and parishes are not considered a medically underserved area out of 252 counties and parishes.
Great. Well, thank you. They've established a great case for us to go forward. They've identified the challenges, the problems that are being faced in healthcare, and whether you concentrate on the rural aspects, you have to identify that this is happening all throughout the states. Some of the slides showed the urban effect. The reality is until we can establish the home and community-based services and the other ways of access, whether it be transportation, telehealth, some of the ideas, innovations that we're looking at, these urban facilities are also getting stressed because they're having the reliance upon using those specialists and the physicians that they just discussed have to come from those areas where the voids are. But I want to get into that, and so my aspect is going to be more of the approach of state solutions coming in, and I'm going to focus on the Medicaid side, the state government paid solutions for healthcare. But first of all, I'd like to welcome you to Missouri, St. Louis. This is the home city for Centene Corporation, and we want to thank Governor Nixon and his staff for hosting and participating and helping with this event. I understand he's got a knee injury or something to that extent. He isn't here. When I was in the legislature, we played, along with Brian May, who's in the back, played on a basketball team called the Capitol Domes, and I would just ask Jeff and the others to let the governor know that his knee surgery is long overdue. He was slow getting up and down the court sometimes. But anyway, Centene is a Fortune 500 managed care organization. We do Medicaid, but we're also expanding into the exchange markets. And we've actually taken on a new line of business that for the past 3.5 years we've been participating with one of our subsidiaries called Centurion, which is correctional institutional care. And it's primarily focused in the behavioral services right now, but even in correctional institutions, along with the subject we're talking about, they're needing solutions, and they're trying to get into primary care, even at those levels. The footprint of Centene is we are primarily in 24 states throughout the United States from the West Coast, but we're very heavy in the southern states where the Southern Governors Association members come from. And we serve 4.6 million members currently. We just did an acquisition of the HealthNet Corporation, which is primarily a Western Coast company. As soon as that merger goes through and the acquisition is complete, we will serve over 6.1 million Medicaid members. We also have exchange. We're also going to have other types of health delivery, including another government surfacing TRICARE with the Veteran Services. My job as Vice President of Business Development and Corporate Growth is new market procurement. I actually go into these states that we're discussing, and it's my job to meet with the government officials. They're looking for state solutions, and something we haven't touched on too much, but let's look at the realities. States want us to save money. The last presentation was talking about the lack of funds, the lack of money, having to pay doctors, having to come up with value-based purchasing, other innovative ways of trying to build networks and keep the provider networks and the provider sources engaged and involved in healthcare to get to those CMS components that you talked about, which indicated that they want that healthy outcomes, but we have to do the other things up front, which means affordable care as well. But there's one other aspect that they haven't discussed, and that's where we kind of come in, is we have to deal with the members. We have to get that compliance. Whether I'm in an urban area or a rural area, compliance is a difficult factor. I have to make certain if I have 100 doctors or one doctor, I have to find a way to get the members to get to the location to where they can get the health care. And so as we complete that circle, we start identifying the factor that the practitioners are also having to fight the odds and elements of sometimes the members are not following through. So we have to get very heavily engaged in care coordination. And the care coordination includes the beginning from transportation, assuming we have the network in place. So these are all the things that we get engaged in, and there's been an evolution of Medicaid been going over. We can talk about ACA, you can talk about all these different acronyms or whatever you want to call it, but we're viewing, as you stated about Australia, to the United States. We're starting to view healthcare in the United States much differently. And to single out a state solution or Medicaid really isn't fair, because the network that I develop and build in a state is going to be the same one that's serving those underinsured, uninsured, or the expansion states, or the commercial pay. Same practitioners, same networks, same benefits being delivered, services. The key differential is going to be what? How they were determined to be eligible for the Medicaid or the Medicare space, and secondly, payment. Reality is the physicians and the networks and the practitioners really don't look forward to that Medicaid dollar coming in. At the hospital level, they'll tell you that they're getting paid 75 cents on the dollar. So they're actually losing money when they come in. And then when you look at trying to get access to care, and if you're a physician's office and you are working in a smaller community such as this, you have to start identifying, well, how many Medicaid spaces am I going to allow each day to be able to pay for this? Then I have the compliance issue. I have a lot of these Medicaid people that aren't showing up. They're not coming to the doctor when they have an appointment. Now I have that open space. So there's a lot of other types of elemental problems that we're faced with as we come in. And when I look at rural health and many of the states that we're serving in, one of the slides showed another term that wasn't mentioned, but it was on the slide about frontier. And you know, you go from an urban area, and I can identify a state similar to Kansas or Nebraska, for example, where if you look at both of those states, along the river, you have Omaha or you have Kansas City, very populous areas. About an hour into the state in Kansas, you'll either have Wichita, Topeka, Manhattan. In Nebraska, you get to Lincoln, maybe to Kearney. All of a sudden, what happens? You can drive for 7 hours across the states, and there's no population. Not really something to look at. You have small little towns in certain places, but there's people out there. But the providers, the practitioners, the networks, they kind of stop. And when you looked at the map, the density map that you showed, if you see those heavy red areas, I mean, that's a very difficult solution to find. But those are the things that we're facing, because all of a sudden you have to start thinking, how do you recruit? How do you get the practitioners into these areas? What are some of the things you can do? I want to highlight a few of those as I go through to tell you what we're doing at Centene to try to meet some of these demands. When you look at the real concerns that we have to identify, it's how do we then, when we know that these gaps exist, what are we going to do to really develop and build that network? Value-based purchasing is becoming a big term right now. A year or two ago, you didn't hear too much about it. If I can, I'm going to give you a little bit of a backdrop to understand what's going on. As you see the evolution of healthcare throughout the states, and many of you in the states that you represent, and what you're trying to do, whether it be North Carolina, Alabama, Louisiana, Arkansas now, other states such as that, Mississippi, just imagine all of those, even Florida, which isn't considered to be a rural state, but I can tell you on a network basis it's very rural. But if you look through these states, every state is looking for a different solution. We have different established. Some will go statewide. You're going to include all populations, and you're going to have 3 managed care organizations delivering the benefits and services, and we're going to have everything from TANF, CHIP, all the way through behavioral, long-term care, long-term support services, and maybe the intellectual, developmentally disabled populations all being served. Or you may have 3 regions in a state, or even such as Florida. We'll have 5 regions, and we're going to include provider-led to compete against the MCOs. So there's so many different models that are out there, but what's the common denominator? We have to find networks. And what are we doing to do that? Well, in current space, because of what has happened in the evolution of healthcare, a lot of the hospitals are trying to become healthcare systems themselves. They're trying to establish themselves as health plans. In the state of New Mexico, one of the largest and probably best running networks is the Presbyterian Health Services. It's a hospital-based service. In many of the other states, Iowa, for example, you have Unity Point, trying to do some established work. You have the University of Iowa, which is represented here today, that has their own network built with the University of Iowa Alliance, where they've taken in over 45 regional health centers and community access centers, along with larger hospital bases like Genesis in the Davenport area, and they've established their own networks. And then the MCOs come in and they want to have a joint venture or establish a strategic partnership with us so that we will come in and we'll do the management, the care coordination, and what we call the backroom support services. And they want to be on that front line helping with care coordination, being those provider systems and developing in, and hopefully at some point being able to take risk. So as you as state government officials call in and look for these solutions, one of the first things you're looking at usually are the savings. You're going to capitate those costs and expenses, you're going to pay a per member per month price, and you're going to ask us to find all the solutions that we can at the same level that we have to deliver to all of the other payment levels, whether it be commercial or otherwise. The types of solutions that we've been finding is this value-based pricing we're talking about. We tie that into performance and into quality-based measures, and it's kind of like we're going to do a reconciliation 4 months from now. Every quarter, 3 months, and then in that 4 month, we'll do the reconciliation. Did you meet your quality standards? If so, usually based upon a health benefit ratio of around 85 to 88, maybe 90%. But generally what we're going to do is give money to these network bases to get engaged, to get involved. And then they have to perform as well. The multiple models and approaches are not that different because at the end of the day, access is the key. Access to care, access, getting the actual members to the care, as well as making certain that it's in place. Some of the things that we're doing, for example, that hasn't been discussed too heavily, but in rural health, especially with a new population that's coming into Medicaid specifically, is in behavioral health. That's an area that's growing. I can tell you that when I first came to Centene about 5 years ago, long-term care was only in about 3 or 4 states under a managed model. It's now in 11 states. Behavioral health, and it should be 15, by the way, based on the procurements we see on the horizon. Over 15 states will go to long-term care over a 3-4 year period. In behavioral health, it was scattered and spattered around, and it really wasn't a full population. It was some kind of service or benefit they wanted. But now it's coming to over half of the states are providing behavioral health benefits and services through managed care. And then we're adding another population that's in 3 states currently, and there's 3 more procurements that they're looking at, is this intellectual and developmentally disabled population. Now let's get to that rural part. Home and community-based services, specialists, personal care attendants, the other types of people that are necessary, the clinicians and practitioners for behavioral health. You can't establish a relationship, and especially in a Medicaid membership that's very transient, establishing these relationships and then break them after 6-8 months and expect to get the outcomes we're looking for. So what are the innovations? What is the flexibility we're looking at? Part of it's recruitment. We're trying to recruit into those areas and make certain that we can find the practitioners to meet the needs. Or we go into telehealth and telemedicine. University of Iowa is very heavily engaged and involved in that, and it usually is in most of the states. You'll find the university-based systems. But what we're finding in behavioral health and in the IDD populations, it's very specialized. Who's going to be in the room with those people? If you're not able to do the face-to-face, and usually when you do, it's a month to 2 months apart is when you have those appointments. We all know that you're not going to get much of an outcome based upon that because there's no follow-up, there's no coordination. Medication is usually involved, and so we have to monitor these things. And so the telehealth and telemedicine industry is growing very quickly into these rural and frontier areas, and we're trying to establish that. But back to what we really need to find is what are the people looking for? What will they respond to? And a lot of it's non-medical. Much of it's going to be the home and community-based services, especially in the long-term care populations. People want to stay home. They don't want to go into institutions. They want the type of care that can be provided. It's kind of like that outpatient surgery we all want. They want the outpatient type of benefits and services as well, so they can go home. We're now having to get more creative and innovative with monitoring systems. State of Nebraska just passed a piece of legislation this past year that many of the states have, which allows nurse practitioners to get engaged in actually becoming primary care providers. That is not the model that we're really looking for, but that's sometimes the model you have to fall back to. And those are the things that are happening in healthcare. So, so that we have time to discuss, but for purposes of Centene and the solutions that we're trying to find, our goal is to come in and to work across that, that full spectrum of care and make certain that we're able to take care of all these benefits. I think the last thing I'd like to point out, and one of the things that we do, is assume in diabetes, which is heavily involved throughout a state in all areas. A podiatrist can be very engaging in assistant or pharmacy or vision care. These are the types of specialists that we have to get in, and a podiatrist could be in an urban area and get $1,600 a day to stay in office and to do the care, and that's what their pay is. Or they can go into the Medicaid realm and maybe travel to one of these rural areas and get paid $650, $700 based on encounters. What our company and many of the other companies are starting to do is we're asking them to come out and set up that rural clinic. Do every 2 weeks or whatever it may be. You're only going to get paid $650, $700 on the Medicaid reimbursements. We'll make up the difference. We'll cover your costs. We need to get you there, because the last point, and this is the beginning, but I wanted to end with it. Right now, the primary focus for these members that may not be compliant or don't have access to primary care in the rural areas are going through emergency room care. That's where healthcare starts in these rural areas, and that's where it ends, because the care coordination and the follow-up is very far and few between, and those are the solutions we're trying to find, because first of all, that's the most costly care, and secondly, it's not the best care in the best place.
Zane, thank you very much. Very interesting perspectives from all three, and let's dive into some of this discussion while we still have some time left. The whole framework of this panel was understanding the healthcare landscape in rural America. And so, Chuck, I want to start with you, and then we'll kind of go down the line on this same question. What is that one piece, that one takeaway for the policy folks as it relates to this, of all the things we've talked about on the multiple perspectives, that one piece that you want to make sure they leave here with?
First of all, on the tables is our care coordination piece for HHS. You're going to see a lot of models that both of my colleagues here referred to. The one thing I would say is you're going to need to think about a collective impact approach that is different in every region. Every region. I want to correct one thing. There are not 19% of our populations living in rural. It's 30. 50% of rural people live in MSAs, and it is 80% of the land mass, and that is the challenge we just raised.
Doc?
Boy, one thing's a challenge, but if I have to hone in for my message, it really is to remind the states the Southern governors represent, the states that they're in, that you have the native populations capable of providing the core workforce of all types, from community health workers up to the physicians, that want to train and return to rural. We have to figure out how to make that both enticing and possible. And I didn't say in my presentation, but we were alarmed to discover in a study about 8 years ago that not only matriculation had dropped from rural to all sorts of health service schools, but in the medical schools, you had seen application rates coming from rural actually stay fairly steady, but the actual acceptances into medical schools at least 8 or 9 years ago were about half what they'd been in 1980. We have to find ways to correct that. Your decentralized training homes really provide a vehicle, and there are new payment methods that the states can tap into, innovation grants, Medicaid waivers, and some excellent economic incentives for doing so that can provide the rural workforce you need to fill these critical access hospitals and patient-centered medical homes. So.
Great. Thank you, Doc. Zane?
Yeah, I think what you're talking in the sense of provider recruitment and ways that we can make certain that the providers not only want to come there, but need to stay there. We need to establish something beyond just a come in, visit, and leave after you've established your practice or whatever it might be, as far as where you can go and sell yourself back to the larger facilities, because we are also living in an environment where most of the physicians are starting to become hospital-based, or what we call employed, and that's devastating to what's happening in rural, because the rural docs that are there are starting to migrate into the urban areas, getting away from malpractice, whatever it may be, or just the actual ability to not work 24/7 and make a living. And so I think if states can find ways to do programs in subsidy, whether it be in education, practices, et cetera, to keep them in the areas.
So let's transition to this innovation that all of you have touched on a little bit. So we've talked about the one thing as a takeaway. Now let's transition that into a strategy, the innovation that you guys have mentioned. So Chuck, why don't we start with you again? The one strategy that you've seen in the States that's touching innovation to address some of this access and now compliance issue that I think is very important that Zane brought up.
I was honored over the last 2.5 years to work with Governor Beshear in a 50-county area in eastern Appalachia, where we created the Shaping Our Appalachian Region. I think it's the most innovative collective impact model in the nation, led by the governor. Here's what I would like to say. Even though we have the moniker culture of health, everything we've talked about to date is about the healthcare system. I want to suggest you have many institutions in your communities and your regions that have to be thought about as creating a stronger culture of health so that Medicaid recip goes to the appointment. This is your school system. This is your church. This is your Rotary and Lions Club. This is your athletic groups. This is any group in a community who decides its goal is to have the most healthy rural region in the United States. This is starting to happen. I would urge that when governors think about integrated cross-sector commitment to health beyond payment and service delivery, but building the culture which trumps everything, we need to recognize the rural culture in many places must be what we overcome. I think state leadership can do a lot to address that.
Bazemore?
So we're blessed as a center to look at a lot of innovations. I'll just touch on one in the training arena that's not in any way new. My experience in North Carolina with the Area Health Education Consortium model, the AHEC model, was really what got me so intrigued by about rural health and providing care there. And I was one who wasn't rural born. The states have, over the years, frankly, lost a lot of their funding and attention to these decentralized training sites, and there remain, again, a number of paths to reinvigorate these. I think I'll mention a second one real quickly that really comes from urban. I think in this new age of payment, where we're going to see all sorts of approaches to population-based healthcare, to value-based payment, I think remembering when you put the community and I would say the primary care team in the driver's seat, whether you look at the Oregon model, whether you look at what some microsystems in Texas have done with Medicare Advantage funding like WellMed, when you actually take the group that more investment in will yield lower overall costs, and you put them in the driver's seat, they create innovative teams that keep people out of the hospital. They're the ones who reach out and say, you know what, we need more community health workers going to lift weights with the obese adolescents in our community. We need to get peer-to-peer relationships going. We need to take that warehouse down the street and turn it into a community center that can actually allow the elderly in our community to do things we know promote health. And there are a lot of examples. I use WellMed as one where this is happening, but you have to have the community primary care teams in the driver's seat. It can't be money that's handed anywhere else.
Great information. Zane?
Agree with the HCBS approach, as well as the innovations to get the providers involved in the outside, the non-medical inclusion. But if I can just contrast it slightly, Obviously, we need to make certain we continue to get the members involved in this, in their own health care. That's the quickest and best way as well. It makes it a lot easier on the provider and the support systems. Few innovations include, we use what we call Cent Account. It's an incentive card that if people will go and get their 90-day wellness checkup, we're going to put some money on that card. It's like a debit card, about $45, $50. Immunizations for kids, give them $20 each time, et cetera. Those are real cards that they can use that are coded. They can't use them for alcohol, tobacco, but they use diapers, baby medicines, different things over the counter that take away that discretionary spending problem, but it puts a little bit of skin in the game for them. In our Mississippi healthcare plan, the CEO there told me that he hates them only because it was the second most volume call he got was, "What's my balance?" But it's ways to get people to do what they're doing. And the last point on the rural aspect, we use Cent Account in Kansas. We'll pay them $1 per mile to go 50 miles or more to make certain they go to their doctor's appointment and follow up.
Excellent idea. Diane, how are we doing on time? Perfect. I'd like to turn to you all, the governor's representatives and some of the audience. Jeff, anybody on your team, you guys want to ask the panelists?
Yeah, the only question I would have is to what extent has it been demonstrated that loan forgiveness programs that would incentivize physicians to locate in rural areas and in exchange they get their medical school debt forgiven, to what extent has that been effective over time in sustaining a provider population in those underserved areas?
You know, we've looked at that in a lot of ways, and I would say it's necessary but insufficient. As you see debt loads mounting, and we are just about to put out a one-page brief looking at the most recent class of family medicine grads, and showing that about 50% are coming out with $175,000 plus in total educational debt, over a quarter with $250,000 in educational debt. Those programs can't grow proportionate to the growth in medical school and educational costs to get there. So I think, yes, they are necessary. They work. They do tend to show at least immediate recruitment retention benefits. I think the real reality is you've just seen educational costs go so high, you're going to need other ways to either narrow the reimbursement gap for all of the primary care groups of providers, but also things like small business loans, ways to make health IT more approachable once you get out into practice.
Jeff, the other thing I'd say is not only the primary care doc, but allied health.
Correct.
And if we are, because that is going to be part of the new model, but if we're really serious about creating the culture of health, and it does lower overall governmental costs wherever it is effectuated, we need to think about nurse practitioners, PAs, behavioral health services, who addresses the home health dynamic with workforce. That is a smaller cost to keep them, and if it was targeted to indigenous rural families in that area, the chance of them staying is much, much higher.
And we moved away from scholarships more towards loan reimbursement. There's again, a new line of thinking that particularly for some of the communities least represented in all of the health disciplines, African Americans, Native Americans, particularly Mexican, Hispanic Americans, not all of the Hispanic communities being the same in their representation, that there is less of a tendency to take on debt in the first place. So you're going to have to figure out how to not only work on reducing the debt burden, but how do you reduce the accumulation of debt in the first place to attract folks into the health professions from communities that you really want to see more involved. So,
And I think, if I can just add, the one thing we notice is the gaps again, is you may be okay in primary care, but you're lacking in specialists. And I think if you want to be very progressive and make certain that you help develop the needs in areas as well, you know, just throwing the program out there sometimes is, as you said, it's not sufficient, but it's a beginning you have to sustain. But I think a lot of times we have to see what the needs are too. And if you can create other programs or plans to get specialists or these other type of care, and that's going to be equally as valuable.
And I think the one thing I'd like to add to this is that in a couple of communities, we haven't seen this necessarily in Missouri, but in some of our other states, we've actually treated the recruitment of physicians like an economic development project.
And we've added other incentives on the table to help subsidize that recruitment like we would do in industry, for example. And we have seen that in some cases really help. The other thing that we've seen is that we have the ability at DRA to help with HB1 visas. You've got physicians that are trained here in America that want to stay, and you've got rural communities that are open, which is sometimes an issue in and of itself, to accept these foreign-born physicians that are trained here in America that are not taking slots away from American physicians. And we have to go through this process, and what we found is that we're seeing more and more of an appetite for that, trying to include them into that recruitment piece. So just a thought from an ED perspective. Any final thoughts from the panelists? Any final thoughts from anybody in the audience? Well, this has been fantastic. This issue is obviously very important. Basic summation from my perspective is partnerships, collaboration. Each state has its own individual models, and this collective thought is very important. And from my perspective, this is as tied to economic development and community economic health as it is to health access and these other issues. So thank you all very much.